Okay. Hi, everyone, and thank you for joining us today for part 4 of the Anesthesia Bootcamp series. I'm Laura Herrera, Vice President of Marketing for Somnia Anesthesia. Today's topic is titled Stretching Coverage, Part 4, Scheduling Surgeon Block from PAT or POM. Joining us today is Dr. Solomon Aronson. Dr. Aronson is an emeritus professor at Duke University and is also the president and CEO of PeriOptions. We will have a Q&A at the end of the presentation where we will be able to answer all of your questions. In the meantime, please feel free to ask your questions in the chat box during the presentation, and we will get to it at the end of the presentation. All of our presentations will be available on our YouTube channel and accessible through our social media channels. The Anesthesia Bootcamp series will be running all month long, so be sure to visit www.somniainc.com/bootcamp for a list of our scheduled webinars. So, without further ado, Dr. Aronson.
Thank you, Laura. I'm hopeful everybody can hear me all right. And as I understand it, you are controlling the slide advancement.
Yes,
So
just let me know.
Perfect, all good. Let's go ahead and move on to the next slide.
Okay.
I want to begin by setting the table and just introducing some quotes that I've recorded over the years, the last few years that I've been really diving deeply into perioperative medicine and perioperative care. And I think they resonate with some familiarity to those of us who practice in this space. I frequently cover the PACU and have seen a lot of patients with previously undiagnosed medical conditions that arrive in the PACU with no prior testing, let alone treatment. I do have to say that when I rarely get to interview a patient more than a few days preoperatively, the average is a day or two before the procedure. And so the onus is on our surgeons to get a sense of risk prior to the patient getting scheduled for any procedure. The priority for the surgical team all too often is only focusing on establishing a medical diagnosis for the surgical procedure and getting the surgical procedure on the schedule. And if the surgeon considered the unrelated medical conditions or uncontrolled myophobal risks that impact the success of the procedure, they may be more concerned. Next slide. And so we're going to talk about OR efficiency, OR productivity, OR utilization, all under the auspices of how do we enhance our capacity management. And I think to sort of set that stage, we should understand what things drive those efficiencies of care. Productivity, or the output over the input, is really in the OR driven by cost constraints, creating an easy to do process to track our behavior of utilization, and all to roll that up to prevent delays and wastes, and to communicate those problems to each other so that we can all work more effectively together for that common goal. Whereas utilization really has been traditionally defined by these classic metrics of on-time start or room turnover. And in order to enhance that, we have to implement preoperative processes that really are fundamental to that point where we do track those efficiency metrics, to minimize the delays and cancellations, and to leverage those trackable analytics so that we ultimately can streamline workflow. Utilization in this context is the actual output over the expected output. Next slide. So I'd like to introduce in the next few minutes the concept that PeriOptions has really stood up as an entity that focuses on managing perioperative care with a focused, if you will, approach to develop an integrative practice unit, or these specialization of core competencies that are brought together under a single focused entity that provide a affordable, a standard, and reliable programmatic approach to the specialty of perioperative care. And we do that through three major deliverables. We obviously provide comprehensive perioperative care services, and we're going to talk a little bit in a moment about what that means, to get a patient ready for surgery, not just to get them on the schedule, but to ensure that their medical conditions are optimized and ready for the perturbation of surgery itself. To ensure that those patient secondary diagnoses that we often don't understand or record are documented, so that enhances all of our abilities to get credit for the risks profiling of the patient, and to show how these ultimately enhance our ability to enhance capacity management. Next slide. For the purposes of this talk, we're going to focus mostly on scheduling efficiency, which is a component of that third tier of what peri-options is all about. Next slide, please. So a few foundational facts. They struck me as amazing when I first began to dig into this, and I think they're worthy of mention. For adult patients who undergo elective surgery today in the US, 70% will develop an in-hospital complication. 40% will develop a home complication, with 15% developing an issue that is significant enough to require them to be readmitted within 30 days of their initial procedure. 70%, probably more, of patients who undergo surgical procedures don't really have a sense of their medical comorbid conditions. And we do a terrible, terrible job of documenting, either because we either don't do it or we under-recognize those medical conditions. So it has great bearing on our ability to understand the needs of the patient. And of course, we still, unfortunately, live in a time when opioid overuse is still endemic. Next slide. When we address these patients preoperatively in a proactive way and try to bend the curve of addressing their secondary comorbid conditions that are unrelated to the surgical procedure itself, we have shown in others that there's a significant reduction in length of stay, a significant reduction in complications, and all that rolls up into a significant reduction in episodic of care total costs. Next slide. So to break that down a little bit more detailed, I would ask you to look at this cartoon that really looks at the journey of a patient as they travel through their healthcare life cycle. And of course, we all live in that blue box where we do things to help us prevent us from getting sick. We try to behave well. We have lifestyle processes that hopefully prevent us from getting sick. But inevitably, it is a reality that we confront the need for surgery often. In fact, it's 9.2 times in a lifetime of a US citizen that we have to confront the reality that we have to undergo surgery. And so once we have to confront that reality that surgery is imminent, we propose that we should do something very proactive to screen, diagnose, and manage those comorbid conditions that influence the outcomes of surgery itself, so that when we actually get to the surgical procedure, what we do intraoperatively is something that is laudable and should be continued. But we have to focus on what I'm going to introduce is that green part of this cartoon and the red part, what we do before surgery and what we do afterwards to pull through. Next slide. So among the predictors of risk for surgery that are modifiable, there are many. There are many that are acquired conditions of just chronic comorbid health, and there are many that are just reflective of our lifestyle choices and our socioeconomic situations. And what we do to bend the curve by addressing those modifiable conditions, I think has great impact on how patients will tolerate and behave from surgery. Next slide. And moreover, after surgery, how we pull that patient through their surgical procedure with respect to post-operative care coordination and our ability to be preemptively focused on high-risk populations also has great bearing on the ultimate outcome of the patient. Next slide. We also talked about the importance of just simply documenting the risk of the patient. And that has a couple of very, very important implications. Firstly, it allows us to understand where our focus needs to be to better take care of the patient so that they're ready for the perturbation of surgery. It also has significant impact on how we can be recognized for doing the work of a care for a high-risk patient. So as we record chronic comorbid conditions or major comorbid conditions, that translates immediately and directly into the return of payment as a DRG yield. Anywhere from 50 to 200% relative weight can be added onto what we would be able to charge and be paid for any one particular procedure based on those secondary diagnoses. And moreover, by recording those secondary diagnoses, it also has a phasic implication in reestablishing the benchmark for our hierarchical coding conditions that define that threshold whereby an institution may be penalized for readmissions or may, on the other hand, be rewarded for shared savings because they're underneath their expected curve. And so it's really, really critical that we do an accurate job of not only dealing with those comorbid conditions, but simply and even initially documenting that those comorbid conditions exist. Next slide. Where this lecture title, I guess, would be focused on is how we enhance the capacity and management abilities of a patient who comes to the OR. Block scheduling is the standard way of allocating time and space to surgeons for doing the procedures. And one of the most critical ways to enhance efficiency is to have surgeons release their unused block time as soon as they know that it's not going to be utilized. And there's many discussions and thought about what is the best way to do that. What we maintain is that when that unused block time is created, then how we fill it with our patients that are coming off the bench, if you will, is critically important for enhancing OR efficiency and OR utilization based on those criteria that we define early on. And so, to be quite frank, how we enable for the surgeon processes to continue to move unimpaired and smoothly is going to be predicated on how quickly and how easily we can fill that available slot with the next available patient, ensuring that that patient is truly optimized and ready for surgery. And that can all be done by integrating and interdigitating our processes that are done upstream. I'm going to pause here for a moment because I know Dr. Koch is also on the call, and he's worked extensively with the C-suites and probably has great insights to share with us the sensitivity of that C-suite with respect to this particular issue. Mark?
Yeah, thank you, Dr. Aronson. Thank you for a very, very wonderful discussion. It's very informative, educational, and useful. So, the best way I've seen C-suites look at this is that if we improve the utilization on a per surgeon basis, because the perioperative care team, the preoperative care team is scheduling into the surgeon's block, that rolls up to improve utilization per OR, which then rolls up to better utilization for the operating room proper. And as that utilization goes up, you don't need as many rooms to provide care to the same number of patients. And what that means is there's less need for nursing teams, which helps with the nursing shortage. Fewer needs for anesthesia teams, which means your shortages in anesthesia are less consequential. So what I've heard the C-suite say is that there's a waterfall effect where these approaches and this approach to the pre-op care helps mitigate some of the adversities they're experiencing with regard to nurse team and anesthesia shortages. And it makes sense because if you think about it, the way things happen right now is when a surgeon has to schedule a case, you usually have somebody that's in their office, they're an administrative person. And oftentimes they're an assistant, an EA, a secretary, a person that mans the front desk. With this approach, you have a highly sophisticated, evidence-driven, protocol-proven approach to scheduling that leads to better outcomes. And, the way I think of it, when I talk to executives at hospitals, is it's kind of like the difference between a hot air balloon getting you from point A to point B. Pull down your thing, the balloon goes up, the wind carries you and you go down, versus a 747, where you have extensive use of monitors, instruments, and multifactorial data that's brought to bear for a smooth and timely, effective takeoff and landing. And I've seen it just work wonders almost immediately for hospitals across the country. And that's my 2 cents. Is that, Dr. Aronson, helpful for me to share?
Of course, and I'm hopeful that there'll be some questions that we can address in the Q&A, but I do think it does deserve to be underscored because it's not a direct connectivity. It requires some sense of the relevance of extending, if you will, the bookends of perioperative services, in that the results of what is done preoperatively to best prepare a patient for surgery not only has immediacy and consequences to patient health and patient well-being for obvious reasons, but it also has an indirect effect on enabling that patient to provide the processes that enable throughput and streamline workflows. And we all know, those of us who have spent, our lives working in the OR environment, that when there is a change in the schedule, an add-on or a shift in the order, that there's a scramble. It's chaotic. It's a mess. And so that if we have processes in place so that that's systematic, and we are assured with great comfort that the patient who's now plugging into that slot because there's a reordering for whatever reason has met all those threshold criteria to be simply ready for surgery, and it does enhance workflow and streamline. And I look forward to having more on that in the discussion period. Next slide, please. So I'm going to walk through this next sort of animation with my sense of the world as it exists now and the world that I believe, stay where you are for a moment here, Laura, how it should look. So today what typically happens is we walk and we talk and we mingle in the ambulatory world until such time when we have to confront the realization that we need surgery. And as I mentioned earlier, that happens often to the average person in the US. And so when that occurs, we go to our GP or primary care physician, or we go maybe to a surgical clinic directly. And there's discussion between the patient and the physician, and there's a realization that surgery is imminent. Next slide. And when that happens, I think we unfortunately are wasting valuable moments, time, between that contemplation of surgery that is generally understood to occur often many, many weeks before the actual declaration of surgery or the scheduling of surgery. And when that occurs, then many, many weeks later, we, after we assign that patient a surgical date of request, we send them just before that, hopefully, to a pre-anesthesia assessment clinic. And there's some things that are done to ensure that we fulfill all our JACO mandated requirement for organization. What we're proposing, next slide, with peri-options is that we change that paradigm, and that when there's that discussion, that contemplation of surgery discussion, that there's also simultaneous, if you will, referral to a healthy before surgery clinic, a integrated practice unit that brings together all these core competencies of getting patients ready for surgery by virtue of their lifestyle changes that can be modified to better enable them to tolerate the perturbation of surgery, or their medical conditions that are modifiable, and take advantage of that window, such that when there is a declaration of surgery and a surgical date request made, that the patient indeed is ready for surgery. We wouldn't ever expect our pilots to land an airplane until the wheels were down. And yet, unfortunately, in the surgical environment, that happens very, very commonly. Next slide. So that when there is that moment where they are sent to the anesthesia, pre-anesthesia clinic, that those other modifiable conditions and lifestyle conditions are already addressed and managed, so that it's much more streamlined, and there is a process to ensure that there's no delays or disruptions in that continuity of care. And finally, and ultimately, what we would propose as a goal, next slide, is that we actually take advantage of that knowledge of getting that patient optimized based on their conditions and the impairment for surgery, to then schedule them directly into the surgical block time based on their available understanding, and our available understanding of their readiness for surgery. I'm going to go ahead and pause there, Laura, and invite the Q&A section session to begin, and hopefully Dr. Koch and I can address any specific questions.
Okay. Yes, I have a few questions that came through. Just need to pop up that window. Give me a second here. Okay. Okay, Dr. Aronson, explain explain using a patient, what their experience would be like for peri-options. So if they used your if the hospital were to partner with you, what would it be like for a patient? What would their experience be like?
Sure. So through the lens of the patient, what we would do is engage with that patient after there was common knowledge that that patient was a surgical candidate, albeit a definitively declared or a patient who is under discussions with the providers that there is likelihood for surgery in their near future. Obviously, these are elective surgical procedures where we have time to have these discussions. And what we do is we do an extensive, very focused evaluation of that patient's medical conditions and lifestyle behaviors with a focused interest in what of those are modifiable and what of those could impact the outcome of their surgical procedure. And then we coach them and we educate them and we guide them based on our knowledge of that interaction, that screening diagnosis interaction, of what kind of therapeutic management makes sense for them to have intercede before their surgical procedure. And the patients are very appreciative of that. We're obviously looking out for their best interests. We want them to tolerate and the surgical stress and to have the best outcome possible. And the fact remains that patients who are sick and poorly managed or not optimized do less well than patients who are sick and optimized, or patients who are not sick. And so our goal is to simply get them ready for this crazy, huge stress and perturbation of their life, which is surgery itself.
And while you were speaking, I had some questions that popped up. I'll give them to you now and then you can answer them. Does it improve patient satisfaction? Does it improve surgeon satisfaction, anesthesia satisfaction? Can you talk a little bit about that?
Sure. Great questions. I'm happy to have the chance to speak to that. Firstly, and most importantly, through the lens of the patient, it does improve patient satisfaction. It's surprising, I would say shocking, that most patients are underappreciative of the impact of their chronic conditions with respect to the outcome that they should expect and can expect from surgery itself. It's scary in that we're so naive to appreciate that some of the things that happen to us in our lives, albeit they are medical conditions, chronic medical conditions, or lifestyle behaviors, impact surgery itself. We think that we have something that goes wrong, it requires surgery, we'll get the surgery and it'll all be better. And we have very, very little connectivity between understanding that that may not be the case if you come to the surgical procedure itself carrying all these other baggage with respect to conditions. And when that's explained to the patient and their families, their satisfaction goes up greatly because somebody is taking a focused interest in ensuring that they have the best outcomes possible. So that's the most rewarding and pleasing and easy part of the question. The surgeon satisfaction is also true in that when we teach them that we're about enhancing patient care and to ensure that their outcomes are the best possible. Some of them are going to be measured by report cards of what their surgical events are and their surgical outcomes are. And so when we sort of present, if you will, the process to enable the best outcome, the best surgical outcome, then that's generally perceived as a very great thing for surgeons. I'll be very honest. The first knee-jerk reaction often is that the surgeon thinks that we're going to prevent them from having a chance to operate, or we're going to put, a monkey wrench in that flow. And that's indeed not true. We just want to take advantage of all the time that leads up to the surgical procedure to ensure that all those other modifiable conditions are optimized. And my experience has been the more and more we work with surgeons, the more and more they receive that as a very beneficial and positive thing. And so their satisfaction goes up as well. We're doing this for only good. And the third satisfaction metric that you asked me to speak to, Laura, was which one?
The anesthesia satisfaction.
Thank you. So that's an interesting one, and it's high for these reasons. We've all been there. I'm an anesthesiologist by my, I guess, DNA, and I practiced for 40 years in an academic environment principally. And anybody in any medical service provider, situation can attest to the fact that it's much more easy, much more pleasing, much more satisfying to take care of patients who are not sick, who are, optimized to, have to undergo the procedure that they are brought to the OR for. And so the satisfaction of an anesthesiologist is great in that the day of surgery, when they have to interview the patient and understand the conditions and to understand the readiness of those conditions for the surgical procedure themselves, it enhances satisfaction greatly because it's just frankly more pleasant. It's an easier day to take care of patients who are medically fit and ready for surgery. That translates into well-being, that translates into burnout, that translates into retention, and all those things that are downstream consequences of just provider satisfaction. So yes, indeed it does.
Great. I think we have time for another question or two. We've gotten a couple questions about costs. So one is about how does it help with the fiscal performance improvement? But then I had another question where someone wants to know, is there a startup cost for the hospital? Who pays for this service? So whatever one you want to tackle.
I'll try to do them all in order.
Okay.
Okay. So cost is obviously a complex discussion, whether it's enhancing margin based on profit and loss, in a sort of simplistic way, or whether or not it's enhancing value in a cost avoidance sort of formula. And both are true. I think if you translate the value proposition of reduction in length of stay, the value proposition in some managed care, value-based contracting, accountable care organization, foundation, where length of stay is a significant driver of cost, then the data has been very, very compelling in what we do and what many others have done in this space to show that there's a diminution in length of stay, readmission rate, as well as downstream complications. And complications, as we know, particularly in capitated or value-based contracting, are crazy, crazy expensive to have to manage. So the reduction in costs can be defined that way. And those data are plentiful and hardy. With respect to the cost of standing up a peri-options kind of clinic, what we found and what we built performers around is that so long as there's sufficient volume of patients that we can see of a payer mix and a fee for service kind of E&M coding, that this is a self-sufficient entity and there isn't any need for subsidy. The other thing that we found is that a lot of hospitals, and this is true across the country, deal with this unmet need in a very patchwork way. And I'm sure anybody on the phone can appreciate that there are providers or institutions that hire people to sort of manage different dimensions of the comprehensive perioperative care world. And so there's a great amount of spend that is already allocated or sunk into the delivery of perioperative medicine, albeit in a way that doesn't really drive that sort of comprehensive deliverable. And so a reallocation or redistribution of those already sunk costs can also help support this. But I think it's really important to recognize that it is a formula that is predicated on the volume as well as the payor description of the clinic itself that is critical for that formula. And in many, many instances, most instances, it can be stood up without any need for subsidy. It's self-sufficient.
Wow, that's great. I think that's all the time we have for today, unless Mark and Dr. Aronson, there anything you wanted to add before we say goodbye to everybody? Good? Okay, awesome. Thank you, everybody, for joining us. Please don't forget to visit www.somniainc.com/bootcamp for a list of our upcoming webinars. The recording of this webinar will be available on our YouTube channel within the next 24 to 48 hours. Be sure to check it out. Thanks again, and we hope to see you guys soon. Bye-bye.
Thank you, Laura.